My name is Jim Kirkpatrick, and I am an assistant professor of medicine in the cardiovascular medicine division at the University of Pennsylvania. Today I would like to talk to you about echocardiography and cardiac masses. Now, I'm not going to be talking about a comprehensive look at cardiac masses, but rather echocardiography, its use in diagnosing cardiac masses, and some of the important things about masses that relate to echocardiography. Well, first, let's start with a case. Here is an apical four-chamber view on the left-hand side of the screen, which is cut down to emphasize the left ventricle. You can see that there's a well-circumscribed mass right there at the apex. And on the right side of the screen, that area is zoomed in. You can see, sure enough, it's well circumscribed. It appears to be arising from the ventricular myocardium. Doesn't extend outside of the heart into the pericardial space. This is an echocardiogram which was recorded from a 19-year-old patient who presented with fever and chills, sweating, and fatigue. Later in the program, we'll actually reveal what this unknown is. But for now, I want to go over an outline of what we're going to talk about. First of all, I'm going to describe some background information about cardiac masses. Then I'm going to talk specifically about primary cardiac benign tumors, then primary cardiac malignant tumors, metastases to the heart, non-tumor masses that can sometimes be confusing. We'll touch on diagnosis and treatment. And then we'll play a game called You Make the Report. Well, cardiac masses have a long history. They've been known at least from the 16th century. It wasn't until 1951, however, that the first non-autopsy diagnosis of an intracavitary cardiac tumor was made via angiography. A few years later, there was the first successful excision of a left atrial myxoma. And a few years after that, echo came on the scene, and the first M-mode recording of a left atrial myxoma was made. Well, what do the guidelines say about echocardiography and masses? Well, number one, it is appropriate, in fact a class 1 indication, to evaluate patients with echocardiography who have clinical syndromes and events that suggest an underlying cardiac mass. It's often hard to figure out what these would be, but nonetheless, if it looks like the patient has a cardiac mass, it's appropriate to do an echocardiogram. Number two, patients who are known to have a predisposition to mass formation. Echocardiography can be helpful in these patients to decide surgery versus anticoagulation, essentially to attempt to identify and distinguish a thrombus versus a tumor. Three, it's appropriate to perform echocardiography to follow up a cardiac mass after surgery to look for recurring masses. Number four, it's also appropriate to use echocardiography to stage primary malignancies, and this is an area that probably gets underused, as we shall see. Number five, echocardiography can screen patients with a disease state that's likely to result in mass formation, but in the absence of clinical signs or symptoms of a mass. Note this is a 2B indication. And number six, it is inappropriate, in fact, just plain wrong, to do echocardiography on a patient when you will have no impact on the diagnosis or the clinical decision-making based on the results of the echocardiogram. Well, let's do an overview of primary cardiac tumors. They are exceedingly rare. The incidence is 0.002 to 0.3% in unselected autopsy patients. 3/4 of these tumors end up being benign. 1/2 of these benign tumors are myxomas. 1/4 of these primary cardiac tumors are malignant. 95% of these are sarcomas. Metastatic tumors are 20 to 100 times more common than primary tumors, And as we shall see, they tend to involve the pericardium, then the myocardium, and then the endocardium. Primary cardiac tumors present with a wide variety of symptoms, and the symptoms are all essentially related to the location of the tumor, its size, its underlying histology, and the friability of the tumor, causing embolic phenomenon. Cardiac tumor symptoms have been put into a triad, and this is classically for myxomas. It includes intracardiac obstruction, and this could be from functional valvular stenosis, which can vary with body position, can actually end up with complete obstruction leading to syncope or sudden death. There's also what's called the wrecking ball effect, basically the tumor on a stalk with each cardiac cycle just bashes into the valve, eventually causing valve damage and regurgitation. We'll see some examples of this. 78% of malignant primary cardiac tumors present with mechanical obstruction because they've gotten so large before they're detected. The second component of the triad is embolic phenomenon, when tumor material or thrombus, which forms on top of the tumor, goes somewhere in the body. Finally, the third component of the triad is constitutional symptoms. These present with a wide variety of symptoms, including fever, fatigue, rash, arthralgia, myalgia, weight loss, anemia, Raynaud's phenomenon, digital clubbing, and of course, when you perform laboratory evaluation, elevated acute phase reactants. And this is probably related to tumor release, or some tumors releasing interleukin-6. Primary cardiac tumors can be found on physical exam. They can be suspected when there's a systolic or diastolic murmur. In fact, in 1/2 of cases of cardiac tumors, these murmurs are present. Loudly and widely split S1 can be caused by a delay in the mitral valve closure. The tumor plop, a classic sign, which comes after the S2 cardiac sound and sounds an awful lot like an S3, can occur in up to 1/3 of cases. Pericardial friction rub is common, especially in patients who have right atrial tumors. And then, of course, there are signs of heart failure, outflow obstruction leading to hypotension, inflow obstruction leading to congestion, either within the lungs or in the periphery. You can see an example here. This is a transesophageal echocardiogram. There's an extremely large mass that's attached to the inner atrial septum, and it exhibits that wrecking ball effect on the tricuspid valve. When you do an EKG on a patient with an intracardiac mass, you can find a lot of different things, including a completely normal tracing. Atrial fibrillation ends up being the most common and occurs in 15% of myxomas. Logically, ventricular tumors produce ventricular tachyarrhythmias. Infiltrative tumors, if they infiltrate the conduction system, can lead to heart block. The main point to remember here is that when you see these things on the EKG, you should keep intracardiac mass on the differential, even if it's pretty far down, that differential. So let's now turn to the tumors themselves, looking at actual etiologies. Here's a subcostal transthoracic view. You can see in the inner atrial septum right here, there in fact is an intracardiac mass. It's attached to the septum, it appears somewhat sessile, and it's extending into the left atrium. This is a myxoma, as is the one here that we see down a little bit lower, or a little bit higher, in the inner atrial septum. Myxomas are the most common cardiac tumors in adults. They occur in the 3rd to 6th decade with a mean age of 56 years. 70% are found in females. And for the most part, they're sporadic, with notable exceptions. The myxoma syndromes include the Carney complex. This is familial in about 10%. It's autosomal dominant and localized to chromosomes 2 and 7 genetic defects. The KRAS genes on chromosome 12 have also been implicated, and the mean age is a lot earlier, 25 years. Myxomas that occur in the Carney complex are more likely to be in the ventricles and to occur in multiple spots in the heart. Essentially, it's tumors everywhere. Skin, myxoid breast tumors, pituitary adenomas, primary adrenocortical micronodular dysplasia, and Sertoli cell testicular tumors are also found along with the intracardiac myxomas. Other syndromes include the name syndrome, nevi, atrial myxomas, myxoid neurofibromas, and ephelids, and the Lamb syndrome, lentiginous atrial myxomas, and blue nevi. Myxoma pathology is gross. In fact, it's downright disgusting. They can grow to be very large in size, 15 centimeters. Most are about 6 centimeters in size, which if you think about the size of the heart, that's pretty large. They can be polypoid, villous, or lobulated. They tend to have large blood vessels at the base of the stalk, and the surface is often covered with thrombi, giving it this rather arresting appearance we see on the pathologic specimen. Micrologically, myxomas appear to have multipotential mesenchymal cells from endocardium, in the stroma. There can be calcification with foci of metaplastic bone, about 10%. This is more common in right atrial myxomas. There can also be extramedullary hematopoiesis. And you can see in the example here, there's free-floating spindle cells and stellite cells, and of course a lot of myxoid ground substance. Location is very important in real estate, but also in myxomas. This is an example of some Philadelphia real estate where I live. 75% of myxomas are found in the left atrium, 15 to 20% the right atrium, and of course the remainder are going to show up in the left ventricle or the right ventricle. They often, in the atria, are attached to the interatrial septum at the fossa ovalis. About 90% are here, and then with decreasing frequency, they're found in the posterior atrial wall, the anterior atrial wall, and the atrial appendage. They do grow at somewhat fast pace every year, on average, of course. There's a lot of variability. 1.8 centimeters per year, this equates to about 14 grams. They get symptomatic in general, and of course this depends on the size of the patient, the size of the heart. When they reach about 70 grams, they can get much larger in the right atrium before they're discovered, because there does tend to be fewer symptoms that are alarming that come from right atrial myxomas compared to left atrial myxomas. And here's one of the key points that I want you to remember. 30 to 40% at least of myxomas end up embolizing. Myxomas can also make a comeback, if you will. They can be recurrent. In the first 4 years post-operatively, this is of special concern. Why does this happen? Well, it could be because of incomplete resection. It could be because there actually were other foci of myxomas which were missed. 12 to 22% of familial or complex myxomas actually end up coming back. The numbers are much lower in the sporadic myxomas. And this has led to a recommendation that echo be performed every 6 months in patients after resection of a myxoma. So here's another tumor. This, as you can see from this transesophageal long axis view of the aortic valve, is hanging off the aortic valve leaflet. It's large and appears to be attached via a stalk. It's fairly well circumscribed, and it doesn't exactly exhibit the wrecking ball effect, but it's definitely moving around an awful lot in the aortic root. This tumor is a fibroelastoma. Fibroelastomas are 10% of primary cardiac tumors, making them, of course, very rare, but this ends up being 85% of all tumors that arise from valve tissue. They occur in the elderly. They look like sea anemones with a short pedicle and fronds, especially as shown in this micrologic specimen. They're generally small, less than 20 millimeters. They're well delineated, and they can often be confused with vegetations, Lambel's excrescences, blood cysts, but they tend to have stalks, which isn't always true for some of these other things in the differential diagnosis. Fibroelastomas are generally attached to the valve apparatus. They occur more commonly on the aortic valve and then the mitral valve. They're very rare on the pulmonic and tricuspid valves. 70% are associated with some sort of valvular disease, whether usually regurgitation. And there may be a high incidence of cerebral coronary and what has been reported in the literature, retinal embolization. But it's still quite unclear what should be done with these if they haven't embolized. One of the points to make, at least traditionally in one series, was that 48 out of 141 were actually missed. So it's easy to miss these, especially when they're quite small. As with a lot of tumors, if something grows larger than 1 centimeter, and of course if there are any symptoms, surgery is recommended. Here's another tumor. This is a rhabdomyoma. And the fact that this is a still frame and not very good quality speaks to the fact that it's pretty rare and I don't have a moving example of it. Rhabdomyomas are the most common cardiac tumor in childhood. 75% of them occur in patients who are less than 1 year old. They are associated with abnormalities on chromosome 9 and 16, may involve tumor suppressor genes. They appear to have striated muscle, quote-unquote, spider cells. They mostly occur in the ventricles. They can be multiple. They can show up as pedunculated masses. They can cause obstruction classically. And perhaps the most interesting thing about it, especially in children, is that their cells lose mitotic ability and there may be spontaneous resolution. They are associated with tuberous sclerosis, which, as you may remember, includes mental retardation, epilepsy, adenoma sebaceum, and hamartomas. Here's another tumor, or rather two tumors. This is obviously an explanted heart. There's a large one in the intraatrial septum, and there's a little space in between, and then there's another large ball-like tumor. And this actually is a rather extreme example of lipomatous hypertrophy of the atrial septum. Let's use this to actually talk about lipomas. Lipomas consist of 10% of cardiac neoplasms. They tend to be encapsulated. There's a wide size variation. They can be intrapericardial, intramyocardial, they can grow from the valves. And then, of course, there's lipomatous hypertrophy of the intraatrial septum, which is essentially a lipoma. There is an increased incidence of supraventricular tachycardia, especially when the septum is involved. There can also be SVC obstruction. It's not hard to see how this tumor could obstruct the superior vena cava. And of course, MRI is very good at showing the traditional fat appearance, fat signal intensity, and of course lack of perfusion when gadolinium enhancement is performed. And here's just an MRI example. We can see a very large lipomatous tumor lights up on the black blood, and it's actually either arising from or going into the anterior myocardium there. Here's another tumor. This is a short axis of the left ventricle. You can see the mitral valve here right in the middle. Down here in the inferior wall, there's a well-encapsulated tumor inside the myocardium. This is a cardiac fibroma. Here's another rather dramatic example, labeled F here, of a cardiac fibroma taking over the heart, essentially. 2.8% of primary cardiac tumors are fibromas. This makes it the number 2 benign cardiac tumor. Central microcalcifications or cystic degeneration can arise because these things grow and outstrip their blood supply. They can occur in the intramural free wall. They can be well demarcated. They can be obstructive, not surprising, and they tend to happen in childhood, but they're very slow growing, so they're often detected as adults, in adulthood, excuse me. Now, even though they're benign, they can grow into the conduction system and cause ventricular arrhythmias and sudden death, and this happens in about a third of patients. They are associated with the Gorlin syndrome, and the Gorlin syndrome includes basal cell carcinoma, generalized body overgrowth, jaw keratosis, as shown here in the picture, and other skeletal abnormalities. So you remember this. This was our first case that we showed right at the beginning of this talk. It's a well-encapsulated tumor here in the left ventricular apex. If you still don't know what it is, here's the pathologic specimen. You can see there's these big vascular channels in it. And this is a hemangioma. 5 to 10% of benign cardiac tumors can be hemangiomatous. They can be capillary, cavernous, intramuscular, just like the one we see in our example. Where they are doesn't seem to influence prognosis. They can present with dyspnea on exertion, angina, pericardial effusion, and of course, if you perform angiography, you can see them light up with a tumor blush of contrast. Total surgical excision, unfortunately, is usually not possible, and patients have ventricular tachycardia and sometimes can be left with large pericardial effusions causing tamponade. They can also spontaneously resolve, and it has been reported that steroid therapy can hasten this. Here's an example of a very large hemangioma. You can see how vascular it is. Under benign primary cardiac tumors, we should also mention mesotheliomas of the atrioventricular node, cardiac pheochromocytomas, granular cell tumors, hamartomas, leiomyomas, lymphangiomas, neurofibromas. These are all in the case report category. So let's review. Primary benign cardiac tumors. Which ones are located on valves, occur in the elderly, and have a sea anemone appearance? Fibroelastomas. Which ones are located in the interatrial septum, can cause atrial fibrillation, 15%, and are associated most of the time with murmurs? That would be myxoma. Which of them occur in the ventricles, can be multiple, and are generally found in the pediatric population? Rhabdomyomas. Which grow out of the walls of the ventricles, are well demarcated, also occur in pediatric patients, but are slow growing, found in adults, and can cause ventricular arrhythmias, especially if they get large enough? Fibromas. And which are intramuscular and very hard to resect? Hemangiomas. And just to make a point, our patient actually did have a successful excision of her hemangioma, and she did very well. Malignant primary cardiac tumors is our next topic, and essentially this topic is all about sarcomas. 95%, at least in this series, of a wide range of years, you can see 1976 to 1993, ended up being sarcomas. Here's a picture of an angiosarcoma. This is a transesophageal view. You can see the aortic valve. And this tumor is actually located in the left atrium and growing and getting very close to the mitral valve, if not having a wrecking ball effect. Angiosarcomas occur in the 3rd to 5th decade. They are actually rare in children. They occur with a male predominance. They occur in the right atrium or the pericardium in about 80%, so our example is quite unusual. They can produce a continuous murmur because they have a large vascular supply, and there can actually be dilated vascular channels which supply these tumors. They are recurrent, and they can cause pericardial effusion and tamponade. They can lead to cardiac rupture. They are rapidly progressive. Survival is 6 months at the very best. Debulking might alleviate symptoms depending where the tumor is and what the symptoms are. There is some reported success with chemotherapy, with radiation therapy and IL-2. There is recurrence with suppression, however, in patients who are transplanted. And usually these patients die from widespread infiltration, intracavitary obstruction, and or metastasis. Here's another example of a rhabdomyosarcoma. And these also exhibit a bimodal peak in infancy in the 6th to 7th decade, so they're found both in children and in adults. They also occur in males. They can occur in any cardiac chamber, but they tend to arise from the left ventricle. 60% have multiple locations. Paraneoplastic syndromes are found in them: hypertrophic osteoarthropathy, polyarthritis, amyloidosis, neurofibromatosis, which, as you remember, caused the cafe au lait spots, and eosinophilia. They are noted to have hematogenous spread, and so survival is less than a year. There may be an effect from chemotherapy, but for the most part, surgery is really the only option. Primary cardiac lymphomas are quite different than these other malignant cardiac tumors. Most of them are non-Hodgkin's cell lymphomas. They can be diffuse B cell type, about 80%. 1.3% of all cardiac tumors can be cardiac lymphomas. Rising incidence is happening recently with AIDS and, of course, transplant immunosuppressives. They're still quite rare, however. They are marked by rapid progression, but, and here's the key difference, they are chemotherapy responsive, and surgery is actually usually not helpful unless it's palliative to relieve obstructive or other symptoms. Then there are a few more, the unusual gang of suspects: plasmacytomas, fibrosarcomas, mesotheliomas, liposarcomas, and even osteosarcomas. Again, most of the case report material. Here's an example of such a case, leiomyosarcoma. You can see this very large tumor located at the base of the infralateral wall, extending out from the heart into the pericardium. You can see how it's obstructing mitral inflow and also obstructing outflow through the left ventricular outflow tract. So let's review primary malignant tumors. Which tumor arises more often in the right atrium or the pericardium, occurs in adults, and has a male predominance? That's angiosarcoma. Which tumor occurs in the left ventricle, can be multiple, has a bimodal peak, but also occurs with a male predominance? Rhabdomyosarcoma. Which one occur in patients who are immunosuppressed and the incidence is increasing? Primary cardiac lymphomas. So now let's turn to the far more common metastatic tumors. Here's a compilation of 4 different studies that was performed in 2004. Each one of the bars on this graph represents the data from a different study. So white bars are all in one study, and gray bars all in another, dark gray in a third, and the striped bars in a fourth. And it's interesting what we can see across these studies. Melanoma, by far, is the most common metastatic tumor to the heart, really, in all of these different studies. Breast looks to be second in many of the studies, followed by lung. Interestingly, 2 of the studies showed thyroid gland metastatic tumors to be fairly common. And then, of course, lymphoma was found in all of the studies. There have been a categorical approach to characterizing metastasis to the heart. They've been divided into 3 categories, including tumors which are uncommon, cancers which are uncommon but tend to go to the heart, and those include melanoma, germ cell tumors, and thymomas. Then there is the category of tumors and cancers which are common and they may go to the heart or may have an intermediate potential to go to the heart: stomach, liver, ovary, colon, and rectum. And then there are tumors which are pretty common but almost never go to the heart, and that includes cervical tumors. Cardiac metastasis shows about a 10% incidence, and then of course if you look at the autopsy patients, it can go up to about 25% of patients dying of malignancies having evidence of cardiac metastasis. The one huge exception appears to be primary neurologic tumors, which tend never to go to the heart. When tumors go to the heart, they can show up in different places. Perhaps the most common is involvement of the pericardium. We can see here in the top middle of the screen. Then they can go to the myocardium, as you can see multiple studded areas in black here on the lower right-hand part of the screen, and they can also show up as intracavitary tumors, either just having the tumor material lodged somewhere within the ventricular or atrial cavity and setting up shop and growing from there, or perhaps even growing in from the wall. Here's an example of a thyroid carcinoma which went to the right atrium and may actually be growing out of the superior vena cava, not well defined here on this transthoracic echocardiogram, an off-axis view in which the right ventricle is on the left side of the screen, the left ventricle is on the right side of the screen. You can see the aortic valve in the middle, and then the huge tumor mass in the right atrium. You can see that on the right side, the right panel here, that there's actually quite a bit of obstruction to tricuspid valve inflow, and essentially functional tricuspid stenosis caused by the tumor. Here's an example of a tumor that went to the pericardium. You see this large circumferential pericardium from this short axis view. The left ventricle is right in the middle. You can see some brightness and almost studding of the pericardium. And then, of course, this mass that's actually growing out in the upper right-hand portion of the screen. This ended up being an adenocarcinoma. The differential diagnosis of metastasis to the heart is wide and includes vegetations, foreign bodies, thrombi, perhaps most commonly. And of course, thrombi occur on the left ventricular apex, most commonly in patients with low left ventricular function, especially with aneurysms. And of course, in patients with atrial fibrillation, it can have left atrial appendage and right atrial appendage thrombi. Wall motion abnormality obviously predisposes to stasis and thrombotic formation, as does low ejection fraction. Thrombi can be pedunculated or mural and can show up basically the same way that any tumor can show up, maybe with the exception of fibroelastomas. Catheters and contact lesions can lead to intracardiac thrombi, and of course thrombi can have embolic potential depending, as we shall see later, even more so on size and mobility. There is also a long list in the differential of things that are just not tumors, but can often be mistaken as such. In the right atrium, these can include the Chiari network, eustachian valves, the crista terminalis, of course catheters and leads, pectinate, fatty infiltration of the tricuspid valve annulus, and venous varices have been reported. In the left atrium, the heart transplant suture lines can sometimes show up as intracardiac masses. The fossa ovalis can look like a mass. Coronary sinus can look like a mass. The left upper pulmonary vein and left atrial appendage ridges can appear to be mass-like, and of course interatrial septal aneurysms, when seen on FOSS, can look like masses. On the valves, we already discussed this, but vegetations, Lambel's excrescences, and then of course just the normal nodules of Aurantius. In the right ventricle, the moderator band can sometimes be mistaken for mass, especially if it's not well seen, and the right ventricle does tend to be heavily trabeculated. Endocardial fibroelastosis can also be very mass-like and fill the right ventricular apex. Reverberation artifacts are fairly common. In the left ventricle, false chords, papillary muscles, trabeculations are all normal structures. Thrombus, as we mentioned, hypertrophic cardiomyopathy and non-compaction. Pericardial cysts, pericardial fat, and then of course even hiatal hernias and lung atelectasis can look like masses. This is an interesting example of a Chiari network. It has a basket-like appearance, which is fairly unusual. Normally they look like just thin rope-like structures. But Chiari networks have been reported in 1.5 to 3% of adults. They have been described as embryologic remnant in a continuum with eustachian valves and full right core triatriatum. They can be site of thrombosis. You can imagine that a thrombus can form within this basket and then go somewhere afterwards. This is another finding which looks very mass-like. You can see in this transesophageal view, right in the middle there is this rather bright structure which appears to be arising from the lateral annulus of the tricuspid valve. Above we can see the right atrium, below is the right ventricle. This is fatty infiltration of the tricuspid valve annulus. It is a normal structure. Cysts have also been reported in the heart. Chynococcus, of course, can show up in the liver, but also in the heart. It's been found more often in Greece, or at least reported more often in Greece and Turkey. Intracardiac findings less than 2% on autopsy series, so it is actually quite rare. They can show up in the LV free wall, the septum, the right ventricle, and the pericardium, tend to be septated and can be calcified. And of course, even though they're technically benign, they can lead to rupture, dysrhythmias, and they can embolize. Pericardial cysts are somewhat considered normal structures. They can be rounded, adjacent to the right atrium is the most common location. And They can be asymptomatic, but their potential for causing problems is in the fact that they can compress heart structures. Blood cysts tend to be congenital. They're actually rare in adults. They appear on lines of closure of valve endocardium, and they can be well circumscribed masses with very thin walls. Here's an example of a hydatid cyst, or two at least hydatid cysts that are seen within the heart. And this is a pericardial cyst. You can see how it's compressing the left ventricle. And here are some blood cysts. These are not necessarily arising from the valvular structures, but they're very disturbing in appearance. One of the main issues that we deal with in echocardiography is the fact that we can miss intracardiac findings. And in fact, when we're looking at specifically intracardiac thrombi, the transthoracic sensitivity can actually be as low as 75%. This is especially the case when we're considering small and laminar thrombi, when there's poor image quality and when there's foreshortening of the ventricle. Of course, we can also overcall findings, and we already talked about a lot of different artifacts and normal structures. There's actually been a scheme proposed to identify artifact versus mass. And just to distill it for you, if it has defined borders, if it has a distinct acoustic texture, if there's an associated wall motion abnormality, if it's present in greater than 2 views, if it's present throughout the entire cardiac cycle, and if you can pretty reliably say that it's not a papillary structure or trabeculation, and then of course if you administer echocardiographic contrast to light up the ventricular cavity and it shows an area of defect, this might be consistent, or is more consistent, with an actual mass, be it thrombus or tumor, rather than an artifact. Now there's some other things you can do aside from giving contrast, which is the example we see in the lower right-hand side of the screen right now. Contrast filling the left ventricle and showing this dark contrast void at the apex of the left ventricle, which is consistent with a mass. We can also perform high-frequency transducer echocardiography. It has a short focal length and can resolve images better at the apex. We can also perform off-axis apical imaging, looking for these structures. We can also do color Doppler imaging. And then perhaps the most powerful thing is to look for change in the characteristics or the resolution of the thing that might be a mass over time. Three-dimensional echocardiography has been proposed to be helpful, mostly in that you can see several different imaging planes all at once and differentiate between cardiac mass. The problem, of course, is that three-dimensional echo has a relatively low frame rate, so you in fact may miss things or see even more artifact. And as we already mentioned, contrast can be used to opacify the left ventricular cavity and delineate the borders of a mass. And as we shall see later, contrast can also be used to check for perfusion of masses to help with the differential diagnosis. Other echo predictors of finding a thrombus within the heart, and these are specifically related to patients who have had a heart attack, include wall motion abnormalities, a low ejection fraction, less than 35%, a large left ventricular end systolic volume index, greater than 35 milliliters per meter squared, indexed, of course, to body surface area, left ventricular aneurysms or dyskinesis. Restrictive filling, interestingly, has been noted to accompany the formation of thrombus within the heart, as has a myocardial performance index, the so-called TI index, performed by tissue Doppler imaging, and that gives us a different scale, so that's why the myocardial performance index here cutoff is greater than 0.6. Echo predictors of embolization of LV thrombi include mobility, and then whether the thrombus protrudes into the cavity or is pedunculated, and this is in contradistinction to mural thrombi, which tend not to go anywhere. If it changes over time, if it has architectural homogeneity, especially an echolucent center, which might signal that the thrombus is active, that there are areas of necrosis and other areas that are unstable. adjacent wall motion, and this time it's actually hyperkinetic wall motion. As you can imagine, if there's a mass within the heart and there's an adjacent segment of the myocardium that, because of its hyperkinesis, continues to hit that mass might be more likely to embolize. Size, interestingly, and low swirling density echoes have also been noted, but probably are not quite as powerful as some of these other bolded issues or characteristics. 40% of embolic risk, in fact, can be explained, at least in some series, by mobility and the shape, if you will, seen on echocardiography. Here's just some examples of mural versus pedunculated, and in this particular case, there's both in the same patient. In the upper left-hand corner, we have a short axis view here. You can see at about 10 or 11 o'clock, there's a mass that's protruding into the left ventricular cavity in the mid-axis view. Interestingly enough, it looks like this patient may have non-compaction. You can see a large area of non-compacted myocardium relative to the compacted myocardium. On the lower left-hand corner, you can see that there is a component of this that is mural, that is sessile and stretching into the cavity. It's very large, but it is in fact mural. But then right next to it, right in the middle of the left ventricular cavity near the apex there, is a ball-like structure which represents the pedunculated characteristic of another portion of this mass. And then on the upper right-hand corner, it's more easy to see the pedunculated aspect of it. And the lower right, you can also see the large nature of the mural thrombotic component. Now here's an example of an echocardiogram, and I have to apologize for the foreshortening in the right image and the image in the center on the bottom. But it appears that there's really not much going on here as far as masses within the left ventricular cavity despite the lowest ejection fraction. But when we perform off-axis imaging, you can see there is a mass at the apex and it's protruding into the left ventricular cavity. This is an example of how we need to be performing off-axis imaging to get all of our imaging planes in to look for these masses. When we do the off-axis imaging, we can better define the border. We can see the full extent of protrusion of the mass into the left ventricular cavity, and of course we can see the full extent of mobility of the mass as well. Here's another example here. You can imagine that this patient would definitely have a predisposition to forming a mass or a thrombus within their heart. You can see the apical four-chamber view in the upper left-hand corner there. There's a massive aneurysmal dilatation of the mid-ventricle all the way to the apex. That's shown in a two-chamber view, somewhat zoomed in the upper right-hand corner. And then the short axis view is perhaps the most striking at all. It almost looks as if there are two ventricles, short axis, side by side in this particular case. It's an enormous anteroapical aneurysm. Now, one of the things that we have a problem with is determining whether there could in fact be small thrombi within something like this. If this patient had had a gastrointestinal bleed or some other reason why it would be dangerous to anticoagulate the patient, although we'd like to, it would be important to know if there was in fact a thrombus and anticoagulation was absolutely necessary, and also give us more information about the characteristics of the thrombus. And this is where contrast comes in. These are contrast images, roughly the same images on the two top panels as we saw on the last, and then another example of an apical four-chamber with a little bit brighter contrast in the bottom panel. And we can see here that in fact there's contrast swirling, there's definitely stasis, but we don't see any protruding masses in there. We do, however, and this is best illustrated in the bottom panel, see that there is a mural thrombus layered in the left ventricular apex. Other techniques, of course, we can use TEE, gives us better resolution. We can see smaller tumors on TEE. CT, CAT scan, and MRI resolution is getting better. It's probably better than this now, but traditionally 5 to 10 millimeter sized tumors, making echo in general, still better at visualizing the masses. CT and MRI are better, however, at tissue composition. We already saw examples of that when we looked at lipomas. The other thing that we can use, although using less now that there are concerns about radiation, is filling defects on radionuclide angiography and also angiocardiography. Of course, there is the risk that when you put a catheter near a thrombus, it's going to go somewhere. But angiography can help us identify blood supply and the vascularity of a tumor. Let's talk a little bit about treatment. A lot of things have been tried, but surgery is really the mainstay for most of these tumors, especially those that are malignant. It's usually curative for myxomal and stromal benign tumors, and it's usually not for vascular and malignant tumors, although it can be palliative. It is important, however, to remember that surgical treatment should be performed as soon as possible because the risk of embolus and sudden death is high even in benign tumors. In fact, 8% of myxoma patients in one series died while they were waiting for their operation. Operative mortality in general is pretty low for myxomas. It's probably, the upper level is probably lower than this now. However, one must remember the conduction system can be damaged after surgical resection. There can also be septal and valve damage that occurs. And of course, perhaps the tumors have not been completely resected. Transplant has been used for unresectable tumors without metastasis. And for benign tumors, the survival range is decent, obviously not as good as for patients who are transplanted without tumors. But for malignant, it hasn't been that good. In one series, 14 out of 21 had recurrence and death from metastasis at a mean of only 12 months. It's been recently proposed that you can cut out a lot more of the heart and get wider excisional margins if the patient can be placed on mechanical support, and this might actually facilitate some surgical resections of tumors in the future, although it is probably not widely performed at this point. Intraoperative TEE, of course, can be very useful in guiding the excision of cardiac masses. It can obviously diagnose immediately the sequelae of mass removals, as we mentioned before, damage to cardiac structures, and of course residual tumor can be seen in some cases. Defects created in the intraatrial septum and the IVC have been particularly helpfully seen if looked for carefully, and valve function can be assessed. Chemotherapy is very limited in cardiac tumors. As I mentioned earlier, there has been some reports of success, but most of the sarcomas are generally treated with anthracyclines, and of these, of course, cause cardiotoxicity. In an already compromised heart, especially after surgical resection, this may not be the best thing. The role and efficacy of chemotherapy and radiation therapy have been poorly defined, therefore, in most of these tumors, except in primary cardiac lymphomas, which has really increased the average survival from 1 month in untreated patients to 5 years in treated patients. However, we have to remember that even X-ray therapy has its costs, and the heart is very sensitive, and radiation can produce cardiotoxicity. Anticoagulation is obviously a very important chemical treatment for intracardiac masses that are thought to be thrombi. Of course, big and embolizing thrombi that have already gone somewhere or are highly likely to should go to the OR for surgical resection, even if it's not technically malignant. And there is this issue of what to do with organizing thrombi, because thrombi eventually will grow blood vessels, will become part of the ventricular wall and lose its embolic potential. And of course, especially for primary cardiac tumors that are malignant, or for metastasis, we should keep in mind that hospice is a very important treatment option. So now let's talk a little bit about the differential diagnosis and look at one particular case. And this is where you get to make the report. So think in your minds about how you would define and report out this finding. You can see this is an apical 4-chamber view. There's one rather striking finding that most everyone should pick up. And then there's a more subtle finding. So to tell you the way I would look at this, in the left ventricular apex, there is a very large mass. It's accompanied by a wall motion abnormality. In fact, I would characterize it as akinesis of the apex with some brightness in the myocardium and probable thinning. This mass is not terribly well circumscribed, and it is partially mobile, mostly due to the adjacent cardiac motion. I think everybody can pretty much pick that up. Now what we've done is we've administered echocardiographic microbubble contrast, and it's lighting up the ventricular cavity, and what we can see is that this large mass is being highlighted. We can see the borders quite well, and it also helps us to define the wall motion abnormality. And one of the things that I want you to notice is that there is no contrast within the mass at all. And this would suggest that the mass actually has no blood vessels in it, or has very few. So now we have a close-up view, and it's focusing on the other finding here, the one that I said that was more subtle. And this is in the extracardiac space. Here you can see the contrast that is lighting up this mass that's outside of the heart. You can see it right there, and then we give a high mechanical impulse. That's that flash of white on the screen. It destroys some, but clearly not all of the microbubbles, and then you can see them flowing back into this big tumor mass that's there outside the heart. You can actually almost see the individual clumps of bubbles that are perfusing through this large mass, indicating that in distinction to what is composing the mass within the ventricle, this is highly vascular. Now, with some of the new echocardiographic techniques, we can actually perform some quantitative analysis using video intensity detection software to actually look at the relative video intensity and therefore the perfusion of the different structures. And so what we've done here is drawn what we call regions of interest in the mass that's within the left ventricular cavity, and that's the light blue circle. We've drawn another one that's colored red, and this one is in the myocardium, in the distal lateral wall. And then finally, we've drawn another region of interest within the mass that's extracardiac. And we can graph this video intensity over time. And so on the left-hand axis, we see pixel intensity in decibels. We see time on the horizontal axis, and then we've labeled the extracardiac mass, myocardium, and intracardiac mass, as I mentioned before. We can see the intracardiac mass fails to show any increase in pixel intensity over time, and in fact is just completely flat in its video intensity. The myocardium shows an increase in pixel intensity, and then it levels off, as does the extracardiac mass, but the extracardiac mass has an increase in pixel intensity earlier, and it levels off at a higher level. And this would suggest that the extracardiac mass has more blood supply, more blood vessels, higher vascularity than the myocardium, and that's saying a lot because myocardium is a highly vascular tissue. If we look at the pathologic specimen of the mass that's outside the heart and compare it to the myocardium, which is the small box up in the upper left-hand corner, we can see when we stain with, for CD34 that there are these brown circles here, and in fact when we perform quantitative analysis on the pathologic specimen there is higher vascularity. And this was consistent with a metastatic adenocarcinoma as diagnosed on pathology. Do not have a comparable assessment of the intracardiac mass because, let's face it, it's pretty clearly a thrombus, and this patient went to hospice. So now let's look at some other potential ways to diagnose echo malignancy versus benign. I want to emphasize here that it's not going to be definitive. Until we have the pathologic specimen, we can't tell for sure whether something is malignant or benign. But in some cases, echocardiography can give some very helpful hints, at least to give us a sense of whether the mass we're seeing is a malignancy and therefore portending a very poor prognosis versus a benign tumor that has a better prognosis. right-sided location tends to mark malignancy. Not always the case, but that is one of the things that we can use, and that's mostly for metastasis. Pericardial effusion and pericardial mass for exactly the same reason. There are exceptions as we've gone over, but again, if it's in the pericardium, we have to suspect that malignancy is what it is. If it does not look typical of a normal structure, rather obvious. If there is evidence of invasion into the myocardium or adjacent structure, and part of that can involve alteration of function of the myocardium, tethering, wall motion abnormalities. And then, of course, if there's a mass adjacent to the heart and a mass inside the heart, that's usually indicative that this is going to be a malignancy. And of course, as we already showed, if it's highly perfused with contrast perfusion imaging, and here's just an example of a tumor that's outside the heart, it is absolutely enormous, and this is going to be much more likely to be a malignancy. Here's an example of a mass at the left ventricular apex near the septum. If we give contrast, you can actually look at the myocardium. It's down here, contracting normal myocardium. It actually lights up a little with contrast. You can see the mass does not light up at all. Contrast also helps us see there's a wall motion abnormality with thinning there. This, of course, is going to be much more consistent with thrombus from the get-go, but if we actually perform our pixel intensity analysis of the mass and the adjacent myocardium, we can see the myocardium is perfused, the mass is not, and of course it's consistent with thrombus. So I apologize that this echo is not playing very well, but hopefully you can identify in the right ventricle there's this enormous mass, and it is extending there. This is a modified apical three-chamber view with visualization of the right ventricle. Absolutely enormous. The other picture, which you can't see, doesn't add a whole lot. This ended up interestingly being a myxoma. It's very, very large. It's right-sided. This tumor, and again, we're going to have difficulty with one of these pictures, but it doesn't add a whole lot. This is a transesophageal echocardiogram. See the interatrial septum up here. So the mass is nowhere near that interatrial septum. It's actually down near the free wall of the right atrium. Tricuspid valve is down on the right-hand side of the screen. This, one would think, would be something consistent with a thrombus, but in fact, it is a thrombus. Excuse me, it would be something consistent with myxoma, but it turns out that this actually was a thrombus. So let's review. Myxomas, primary malignant cardiac tumors, are two primary cardiac tumors that we discussed. And for all intents and purposes, the benign ones are myxomas, the malignant ones are sarcomas. Then there's metastases that we discussed. There are non-tumor masses, which always have to be kept in mind, even though it's a really, really long list. Diagnosis and treatment. Treatment is generally not very good and for primary malignant tumors and metastases, but echo can provide some really key and important diagnostic tools. So I wanted to thank you very much for your attention.